Greetings, network. You're welcome to today's echo session. I can see we already have 122 people that have connected, and we're expecting more people to join. So let's encourage those that are yet to connect, that they do so. And for those that have joined as a team or from a hub, we acknowledge your presence as well, and everyone else that has come through to today's echo session. So today, 12th August, we are looking at the National Multi-Pathogen Diagnostic Program. We are going to dive into the overview. And then, of course, our presenter today is Mrs. Taurai Machawi. You're most welcome to today's echo session. Yeah, and I'll be your facilitator, Kabaso Mwewa. And of course, we do have the expert of panel of experts. And among them, we have Patricia Kafweta, who is here in the Echo Hub. You're most welcome. Let's see. There she is. Afternoon. And then other experts on the call today is Dr. Foloshi Sombo, Mr. Pao Chonga, and we have Dr. Movangam Tale, and of course, Mr. Swilanji Sirwamba. So these are part of the experts that will be available as we go through this interesting topic, National Multi-Pathogen Diagnostic Program. So we do understand the echo etiquette. I'm sure we've always been connecting, but if you are new, let's always remember to keep our mics muted. And if we're in an environment where the video will not be conducive to be turned on, we make sure that we also counter check and we turn it off. And then you only turn on your mic if given a chance to do so. But as the didactic presentation is running, let's make use of the chat box. We can throw in questions, and I'll be able to read them when we come to the plenary session. But we encourage everyone to be present and to actively participate even as we run through the pause. Mrs. Taurai, you're most welcome.
Okay, fine.
Yes, we encourage the network to mute. Okay. Thank you. So I'm going to allow Mrs. Taurai to just introduce herself and to take us through the didactic presentation for today. And of course, we have to acknowledge that with this network, we do have the IT team, that is Mr. Mvola Chatonda. And of course, the coordinator for today is Kundamwela for this wonderful echo session. So, Mrs. Taurai.
Thank you very much, Dr. Kabaso. And good afternoon to the audience and the colleagues that have joined into this echo session. So as has been mentioned, my name's Taurai Machawi Musonda. I'm coming from the Ministry of Health, Pathology and Laboratory Services Unit. And today we will be sharing on the National Multi-Pathogen Diagnostic Program, a program that has been recently launched by the Ministry of Health. And it's focused on supporting patient-centered care through strengthening microbiology and molecular techniques. And we are here to just give an overview and just to share with the masses what we expect or what we anticipate to see in the landscape of diagnostics. Thank you.
Thank you. We are very much expectant, and we are ready to learn today. So we'll start with a poll so that So we'll start with poll number 1. And I'll encourage the network to participate even as we launch the poll. Okay, so according to the national standard, all second-level hospitals are able to do culture and sensitivity on microbiology samples. It's a true or false question. According to the national standard, all second-level hospitals are able to do culture and sensitivity on microbiology. And I'll allow this poll to run for 1 minute. And these are 60 seconds. You can see the network is actively responding. We're at 55% response. We encourage everyone to participate. Like you always know, what we have are the statistics, but not the individual answers. So even as you participate, it's not like we'll see your individual response, but we'll have a cumulative feedback on our end. So everyone is encouraged to participate.
Okay. The responses are exciting.
Yeah. So the next 3 seconds, I'll end the poll. Okay, so Mrs. Taurai, from 71% that have participated, 79% are saying true. According to the national standard, all second-level hospitals are able to do culture and sensitivity on microbiology samples. And then we have 21% that are saying false.
All right. Thank you very much for the responses. We take note of them. And let's see whether what we have reflected here is exactly what is pertaining on the ground. Okay, so in the past, we have noted that sub-Saharan, and this is basically narrowing down to the topic under discussion on the multi-pathogen diagnosis, we are vulnerable to infectious diseases, epidemics, and this could be due to our climate, our ecological conditions, and these ecological conditions are to do with the vectors and the pathogens that we interact with, and also the high interactions that we have in terms of human and animal. And this has also enhanced the infectious diseases, the spread of infectious diseases. Then what has also been noted is that we have a low capacity to manage epidemics. I think this can also be seen from the recent past epidemics that we have encountered as the sub-Saharan region, as well as narrowing down to Zambia in particular. And there is inadequate resources actually to cover for early detection, identification, as well as prompt response to these epidemics. Then we also note that only 55% of second-level hospitals and 23% of third-level hospitals are able to provide culture and sensitivity testing. And this is in accordance with the National Strategic Health Strategic Plan 2022-2026. And then based on this, clinicians are usually forced to make or treat patients using empiric therapy. And this, we have noted, has contributed to poor treatment outcome as well as antimicrobial resistance. So with the National Multi-Pathogen Diagnostic Program, we had an initial focus on, or an initial discussion on how we were going to take the approach as far as implementing the program as a whole and ensuring that we speak to some of the challenges that have been highlighted in my previous slide. So the initial focus we discussed or agreed was to focus on respiratory conditions and conditions affecting people living with HIV. And this is basically narrowing down to the central nervous system and sexually transmitted infections. Then we also decided to say that, okay, we needed to improve diagnostic capacity and scale up surveillance systems in order to improve patient management and outcomes. So the open PCR testing is actually being implemented currently in 3 sites, and the 3 sites are Livingstone University Teaching Hospital, the University Teaching Hospital here in Lusaka, as well as the Chinsali General Hospital. So you will note that this is a phased approach. We intend to cover the entire country in terms of implementation. However, to ensure the effective programmatic management, we took a phased approach, and we are later to roll out to other facilities. Okay. So this was all done in consultation with MOH and also the facilities themselves and other stakeholders that are working to support the laboratory services as a whole. So we intend to provide microbiology facilities that will enhance testing. And part of this process then entailed that we needed to assess the sites and identify the needs to ensure that even as we begin with the programmatic implementation, all that needs to be observed would have been taken care of. So in order to ensure that we cover the entire landscape as far as laboratory testing is concerned, we had to design a laboratory network and also define what the functions of each tier are going to be. So in the slide you can see, you would note that we have 4 different tiers. We have the spoke site, we have the hub laboratory, we have the open PCR laboratories, as well as the genomic sequencing facility. So you would note that these different tiers of care have got designated responsibilities or roles that they need to take care of. So right at the spoke site is where we will collect the sample and refer it to the hub laboratories. And in these hub laboratories, you will expect to find microbiology testing services, and they could be limited and they could be at full scale, but not necessarily covering the open PCR. Then we have the hub laboratories themselves. So these receive samples from spokes and courier to open PCR labs. And then they perform a certain level of microbiology testing. So after you have your sample collected at a spoke site, it will then be transferred to a hub laboratory. In the situation that the spoke site is able to perform microbiology testing, to a certain extent that would be done, but where it is not able to be done, it will be referred to the next level, and that's where we expect to find microbiology testing. And then we have the open PCR laboratories, and in these open PCR laboratories is where you expect to find the multi-pathogen diagnostic platforms, and these are responsible for testing with microbiology and open PCR capacity. So after we have done the open PCR laboratory testing using the multi-pathogen platforms, we then have the genomic sequencing sites. So you will note that from the diagram that's on this end, where you can see my cursor, we have the genomic sequencing facility. And from this genomic sequencing facility, we can see how samples are moving. So we have samples moving from the open PCR laboratory to the genomic sequencing facility, and also right from the hub straight to the genomic sequencing facility, depending on the circumstances that could be prevailing. And you would note that not all the samples will be tested here, but a selected sample size will be referred to the genomic sequencing facility.
Okay, so we'll run the second poll, which is poll number 2. And we can see even with the initial poll, we've gotten some feedback in terms of the culture and sensitivity. So with the second poll, the following cadres have a role when it comes to the national multi-pathogen diagnostic program. So we've got A, surveillance officers, B, the clinicians, C, laboratory staff, and D is all of the above. I can see the network is actively responding. And, even on this platform, we have everyone, the clinicians, people from the EHT, people from the lab, and everyone else, the implementers present. And so we have this one. Are you a part of this national multi-pathogen diagnostic program? Okay, the network is encouraged to participate. I'll allow the poll to run for the next 5 seconds, and then we'll close it. Okay, so from the feedback, we have 99% of the participants saying all the above participants, they have a role to play. Okay, so.
Okay, this is great feedback. So we then move to the clinical workflow. Based on the previous slide that we may have seen, you would note that there are different areas in terms of different tiers in terms of care. And in all these tiers, we would, some would entail that we have a requisition that could be coming from the clinical setup or the clinicians themselves, and some of them would entail that the sample would just have to move. So to ensure that we have a standardized practice as far as the clinical workflow is concerned and as far as the diagnostic process is concerned, we have more designed a flow that provides guidance on what is to be done. So you would note that clinicians will initiate the diagnostic process, and then the program case investigation forms will be used to capture the patient data in real time. And this will then be transcribed into digital records. And these digital records are going to be used for various purposes. Could be compiling information for onward transmission in terms of reporting, and also just for analysis purposes for it to inform us on different aspects as far as the program is concerned. Then we also have an aspect of the notifiable diseases, and the clinicians will have to ensure that the case definition is met before the samples are collected for laboratory testing. So we have to, as much as possible, ensure that all the demographics, the history is captured in totality, so that even as we have these samples running through the process, and even when they get up to a surveillance, we have all the necessary information that needs to be utilized at the different levels of testing. So from my workflow here, you can see that we have the entry point there. And from the entry point, we have OPD, for example, we have ATS, where we have the chest clinic, the STI clinic. So you would note that this is also designed to speak to the first part of diagnostic or the infections that we are going to be working with. And then when the patient meets the case definition, they would either take two routes. So we have one route that's speaking to the inpatient, and we also have outpatient as well, but these are considered high risk. And then we have different conditions enlisted there. We have meningitis, we have encephalitis, and then we have this wing as well that would take care of the outpatients, including others that we may have not defined here, and then the STI patients as well. So after that, this would then be transferred to the open PCR facility for testing. Then you also note that we will have also taken care of potential samples that of potential outbreak, as well as viral infections and novel threats. And you would note that these will actually also be transferred to the open PCR testing laboratories. So this algorithm is basically designed to inform who it is that has to be or has to receive testing using these platforms. As we may know, we are riding on other microbiology systems that are already being implemented, and this is coming on to enhance what is being done, and this in particular is PCR testing. So in certain situations, we would have to refer back to the conventional way of doing the microbiology testing. Then you want to note that we have also described the high-risk groups. So we have the age there, we have those with comorbidities, could be diabetes, hypertension, asthma, could be renal and cardiac disease, malignancies, and cirrhosis, just to mention a few. Then we also have designed a laboratory workflow. So in the laboratory, for my fellow laboratorians that could be in the audience, you would note that we have what we commonly refer to as an algorithm or a workflow that probably guides how it is that we are going to manage our testing. So you will note that samples will be collected, and then they will either be stored and transported under specified conditions, ensuring that the integrity of the sample is maintained intent. So this is a very cardinal aspect as far as testing is concerned, and it forms the pre-analytical stage of testing, and it defines what it is that we are going to get as an output at the end of the day. So this would have to be observed, and there are recommendations as well as guidelines on what is to be done as far as sample collection is concerned. Could be the containers, could be the temperature that is required. Then transportation to the labs should be within the shortest possible time. So we also want to ensure that even as we observe our algorithm, if samples are moving from a spoke to a hub and then eventually moving to the PCR testing laboratory, the shortest time possible is observed. And this is mainly going to be integrated in already existing specimen referral system. So as a country, we have what we are referring to as the integrated specimen referral system. And our expectations is that even these samples will ride on that system. Of course, we might have instances where we might have ad hoc requests where the sample will require special conditions in terms of transportations, and this could be when we are suspecting that we are going into an outbreak and different circumstances. But all in all, we anticipate or we expect that the already existing courier system would work to support this process as a whole. Then we also have an aspect in terms of retention of results. So we are going to use different systems depending on what's established at the different levels or the different facilities. So in some of our facilities, we have implemented laboratory information systems, could be DISA, and that could be used to relay the results to the requesting facilities using DISA link and other electronic methods. Other than that, we are also expecting to ride on the integrated transportation system, where we now confer the results using a hard copy. And this could be when the samples are being delivered at the facility. If we do have results that need to be taken, they are taken. And even when there's no sample delivery happening, we can then request to say we have results that need to be transmitted to the facilities, and that should be done. Then we also have to have designated MOH biobanking facilities. So these biobanking facilities will be identified for long-term storage of samples, and it will not be necessarily in every facility. However, this has been defined and well illustrates which facilities it is that we are going to use for biobanking. So in a nutshell, we have requesters send microbiology requests. Then if at all there's microbiology capacity that's available at the spoke site, the testing is done. If not, we proceed to refer that sample to the hub laboratory. So you would see that we have an arm going this side where testing is performed, okay? But in as much as testing is performed, we may have situations where the testing is not able to be done at the spoke facility, and then it will then be referred to the next testing facility, okay? And then we have a situation here where testing has been performed, and then the sample would then move to the next part, which is the open PCR platform. So this design basically outlines how the sample is to move from one point to the other. Then when we have the microbiology, we have the samples referred to the hub laboratory for testing or for courier to the open PCR. If at all it is couriered, it lands in the open PCR where the testing is now to be done. If not being done at this level, it will then be referred to the open PCR testing laboratory. So you will note that even in the earlier shared network design, some of the hub laboratories are the ones that have been identified as the open PCR laboratories. And we have some laboratories that are just going to do open PCR testing. Then finally, we have the multi-pathogen microbiology and open PCR performed. And then we have referrals that are done now or samples that are sent to the genomic sequencing at the reference laboratory. And then eventually the data is shared, specimens, isolates are stored in the biobanking facilities that would have been identified. Okay, so what facilities then have been identified to support this open PCR testing? So you would note that we have facilities in each of the 10 provinces. So we have Southern Province, and in particular for Southern Province, we have the Livingstone University Teaching Hospital. So this facility is actually up and running in terms of testing. Then Lusaka, we have the University Teaching Hospital. The facility is actually up and running in terms of testing. Then we have the Eastern, we have the Central Province as well, where we have Kabwe Central, we have the Copper Belt, where we have the Ndola Teaching Hospital, we have Northwestern, where we have Solwezi General Hospital, and then we have Muchinga, where the testing is actually up and running as well. Then we finally have Northern, Wapula, as well as Western. So other than the three that I have highlighted to say the testing is happening, the next facilities or the other provinces are to be supported in the next phases of the implementation or the rollout.
Okay, so we have another poll, poll number 3. Just to say thank you to the network for the participation that's coming, and even on the third poll, everyone is encouraged to participate. Okay, so the third poll. Okay, if you can see it, specimen types that will be considered for this national multi-pathogen diagnostic program initially included all the following, except. This is a very nice MCQ because it says except. So we have A, biopsy, B, CSF, cerebrospinal fluid, C, that's the genitourinary specimens, and of course, D, respiratory. Okay, glad to see that people are responding. The specimen types that will be considered for this national multi-pathogen diagnostic program. Okay, allow this to run for the next 5 seconds. The network is encouraged to participate. So far, we have 240 people that have joined, and I'm sure others have joined in the hub. So even from the hub, you can agree on the response you want to give, and then you give us feedback. Okay, so we'll end the poll and just share the results. So you can see we have 65%, they're saying it's biopsy, that's the exception. And then we have 14% that are saying it's respiratory specimens, and then 13% are saying genitourinary, and then 8% are saying CSF.
So the most are leaning towards the biopsy.
Yeah.
All right, thank you very much, facilitator. So in terms of the specimen types, what is it that we are going to be required as far as the different systems are concerned? So you would note that we have disaggregated by the systems. We have respiratory, we have CNS, we have the genitourinary, and under the sample type, for example, under respiratory, we have swabs where we'll have the nasal or nasopharyngeal or throat swabs. And then we have also specified the container type. as well as the quantity. So this is very important as it forms part of the pre-analytic stage where the collection is happening. So under respiratory, you would note that we also have sputum, we have the bronchoalveolar lavage, we have the tracheal aspirates, we have the pleural fluids. Then under CNS, we have the cerebrospinal fluid, and here we are expected to collect the specimen in a plain container, the red top as we usually call it, or if we have the CSF bottle, that is the one that would be used. And there we also have the quantity well stipulated. We would need 5 to 10 mils at a minimum. Then we have the pus aspirates, we have the blood culture, we have the swabs under the genitourinary, and we have the urine as well as the scrapings. So you would note that this information will mainly be provided within the different facilities, clinical or laboratory handbooks. And these handbooks would definitely be conferred to the facilities that are feeding into this process. And this would be the hub facilities, this would be the spoke facilities, just to ensure that we have standardization as far as the sample collection is concerned, the containers that are being utilized, as well as the quantity. And this will then take care of our rejections, as we want to ensure that we, as much as possible, abide to what is needed as far as the pre-analytic phase is concerned. So we have the Open PCR platform that we are speaking of, which is the Quant Studio 7, projected in the slide that we can see. And then we have the general principle of the PCR. So you would note that even when this testing is being done, as far as the infrastructure aspect is concerned, we are as much as possible abiding to the requirements for PCR. So we have the clean room, we have the extraction room, and then we have the amplification room. So what we expect is to have the clinical sample, and once the clinical sample is received, then we do the DNA preparation. After we have done the DNA preparation, we then move to have the amplification done so that we narrow down to our target DNA, and then we finally do the detection utilizing the system or the platform, which is the Quant Studio 7 that we can see. So we have taken care of this even in our implementation. So in the facilities that we had mentioned earlier that have this program up and running, as far as implementation is concerned, you would observe that the different aspects of the open PCR or the principle of PCR are being observed. So we have a total of 33 pathogens that are to be identified using the kits that has been employed. So you would see that we have the adenovirus, we have the coronavirus, HKU1, we have the enterovirus, we have the Haemophilus influenza, we have Klebsiella pneumoniae, and we are glad to actually mention here that we are already seeing this from the facilities that are up and running and providing testing for our patients. So we have a wide coverage in terms of what pathogens it is that this platform is able to pick and dictate to inform clinical decision making.
Very interesting discussion. 33 pathogens. I'm sure we'll make the most of this platform. So we have another poll here, which is poll number 4.
Where's your phone? Okay, so let's. So just have to do.
We advise the network to always keep the mics muted, and even as we follow through this nice presentation. So the poll, I can see people are still responding about genomic sequencing under this national multi-pathogen drug program. So the following statement is true or false. All pathogens will be subjected to genomic sequencing. Okay, single answer, true or false. Is it all pathogens that will be subjected to genomic sequencing? Okay, let's continue responding. See 44% feedback. We encourage the network to participate. The next 5 seconds will end the poll. Is it all pathogens that will be subjected to genomic sequencing, true or false? In this interesting national multi-pathogen diagnostic program. Okay, so I'll end the poll here. And so network, as you can see the feedback, we have 53% that are saying false. And then now we have 47% that are saying all pathogens will be subjected to genomic sequencing. And that's the feedback, Madam Tyra.
All right, great. Okay, so for the genomic sequencing, just after the poll, we have something that is giving us information on how and which samples are going to be subjected to the genomic sequencing laboratories. So it will be the highest tier of the network. You may have seen even in the design that it was actually sitting on its own. So it is the one that is going to be like the highest level, and the criteria of the pathogens that are going to be sequenced will be based on the National Genomic Strategic Plan and the Zambia Genomics Consortium. So we have a consortium that mainly sets to provide guidance in terms of the genomic surveillance as well as sequencing. And this is the consortium that will be responsible for stipulating which pathogens it is that we are supposed to subject for testing. So the aim of this is to basically identify and understand the genetic makeup of the pathogens to aid public health, and then to provide information regarding tracking and controlling disease outbreak. So this is also a very big part of the program, as it helps to focus on where we are going or what it is that we intend to put in place, even as we continue to look at what is prevailing in our various provinces, our various regions. We have also designed an implementation strategy. So in this implementation strategy, we had to ensure that we first of all identify what is prevailing on the ground to ensure that there's absolutely non-duplication of efforts. So who is supporting the microbiology space, for example? What is it that is being provided? So this was done in consultation with MOH, as well as the different stakeholders that are working to support the laboratory services. So we had a stakeholders engagement that was held to more of discuss the way forward as far as the open PCR testing is concerned. And suffice to say, this is a continuous process. Even as we move towards implementation, we have review meetings where we sit with the different stakeholders, discuss what is working and what is not working, identify areas of continuous improvement and areas that need to be addressed with immediate effect. Then we have also worked to identify unmet needs by other partners that the NMPDP can cover using platforms like the current meeting. So what needs is it that needs to be met? We need to listen to you, the audience, you, the recipients of the service. What is it that you think is not happening? So we have devised different forums where we anticipate to share and also gather the unmet needs that needs to be filled. Then we also have to support to the extent possible the consumables as well as the technical support in terms of testing and also the functionality of the equipment. So we want to note that we have ancillary equipment, we have the Quant Studio machines themselves that need to be serviced, and all that has to be part of the implementation strategy. So in a nutshell, you would see that we have one tier that speaks to consultants work with MOH on the facilities to be supported. So this consultation was done just before we actually did move into the step of having the stakeholders engagements. And then we also had to identify the gaps in the facilities, and this was done using a MAT report as well as site readiness assessments, where we had people physically visit these facilities that were identified by the Ministry of Health to establish what capacity is pertaining, with, of course, the open PCR in mind and what it is that needs to be addressed prior to the process of implementation. And then we also needed to synergize efforts with other partners and implement interventions. So in synergizing the efforts, we needed to identify what support is available in this region. What are they doing? How can we then ensure that we work together towards one goal with no duplication at all? Then we also have program components. So these components mainly stipulate what you expect to see in terms of the overview of the program. So the first one is the assessments. So the assessments are basically meant to identify what is pertaining on the ground, and these are the site readiness assessments. But added to the site readiness assessments, we also are working towards designing a standardized checklist that is going to evaluate the process of implementation, and this will be done periodically, where we'll have people visit a facility that is performing this testing, evaluate what's happening across infrastructure, quality control, external quality assessment, the equipment functionality, and everything that is to do with the running of the samples. And this is also meant to include the clinical aspect that's feeding into the process. So these assessments are meant to be comprehensive, and these are done at inception as well as the program is running, just to ensure effective program implementation. Then we have capacity building and succession planning. So here we look to employ trainings, and these trainings could be centralized, and they could be trainings that would be done within the facility. And you would want to note that in the facilities that we are already having the testing, we did conduct thorough trainings, starting with the clinicians as well as the laboratorians that are performing this testing. And upon training, these laboratorians are expected to be competency assessed so that we can guarantee the quality of examination results. Then we have infrastructure, which forms a very big component of PCR testing. So evaluations are done prior to the deployment of the equipment, and what needs to be addressed is addressed in terms of the requirements for PCR testing, and there is now periodic assessments that are conducted to ensure that we are abiding by the infrastructure requirements, so we can well take care of aspects of contamination and contamination which could be very notorious and very difficult to manage in a PCR testing facility. Then we have data and information systems. So this forms a very big component of the program, especially that we are going all the way to genomic sequencing as well as speaking surveillance. So we have devised systems, and these systems are still being strengthened. So we have both electronic and paper-based systems. So for the electronic systems, we are riding on what is already existing. Could be smart care for the clinical setting, could be DISA for the laboratory. We also have e-labs that could be utilized. And for paper-based system, this is mainly to speak to facilities that may not have the electronic information systems. They can still write with their paper-based system, and this is basically just me using paper. Then we also have to speak financial sustainability. So beyond the support that we have currently for this program, how is it that we are going to manage this program to ensure continuity? So we have designed a program, or rather an implementation guide, that is going to speak to transition, the support, and ensure that we incorporate as much as possible what is required. And this could include the reagents, the consumables that are being used, for example, incorporating that into the pool of procurement using the forecasting and quantification that is done by the Ministry of Health. So financial sustainability in terms of equipment maintenance as well. How do we work to ensure that this equipment is routinely calibrated as per the manufacturer's specifications? Then we have quality management systems, which is a very big component as well. So to guarantee the quality of examination results as far as accuracy, reliability is concerned, we have to employ quality management systems, and we are definitely going to ride on already existent systems just to guarantee the quality of results. Then finally, we have the monitoring and evaluation component, which is basically supposed to look at the program as a whole, evaluate how things are running from one end to the other. You look at the entire chain of custody, what areas of improvement needs to be identified, what is working very well, what can we replicate at Livingstone that seems to be working very well at Chinsali, for example. So in the assessments, I will just briefly speak to the aspects that are to be covered. So we have the current diagnostic network. How is it that we are going to ensure optimized testing, and we'll actually have to work with the DNO just to ensure that even as we map the labs, which labs move their samples in terms of spoke to the hub and finally to the open PCR testing. We have the staffing levels at the facility that's performing the testing. We have personnel competency. We have the equipment itself in terms of functionality, calibration, as well as just the routine maintenance. Then we have the lab facilities. Are we abiding by what it is that we need to abide as far as open PCR is concerned? Do we have the 3 rooms? Are we taking care of contamination to the extent possible? Then we have the reagents and consumables as well. Do we have a functional supply chain? Are we ensuring that we are recording and documenting our utilization, requesting for reagents in a timely manner so that we ensure uninterrupted service? Then finally, we have the data and information management. So this will be covered under the routine assessments that I had mentioned earlier, just to ensure that we have a constant eye on the program. So capacity building and succession planning, we have trainings, we have clinical capacity, which will include appropriate case identification, documentation, sample collection. Then we also have echo sessions. For example, we have e-learning, we have webinar sessions, as well as we have the mentorship as well. So echo sessions, one is such a kind, the one that we are in. So we will ride on these platforms just to ensure that we have as much capacity being built, as well as dissemination of information going on. Then in terms of mentorship, we are also going to ride on existing systems. So we have what we are referring to as the Copper Belt microbiology mentorship team, as well as the Southern Province microbiology mentorship team. So these teams have already been established. So we will strengthen those teams and ensure that they also participate in the mentorship program for the open PCR and just synergize with support and capacity that is already available. So here we see the Copper Belt microbiology team that we are going to be working with. So this is being supported by one of the partners, and this is an example of the synergy that we are speaking of. Then infrastructure, we have to ensure it's standardized. We have to leverage on public-private partnerships. And we also have to ensure that we have long-term infrastructure support. And this has to be incorporated in the strategic plan, as well as the infrastructure guidelines that the Ministry of Health is currently developing. Then data and information systems. So we have already spoken to paper-based, smart care, DISA, e-labs. We have to ensure that we have a centralized, secure, and interoperable information system just to ensure that we can easily retrieve information at the different levels, even at national level, if at all we need to have access to information for decision making. This should be done easily. Then we have to ensure that we have real-time reporting mechanisms. So in cases of disease outbreaks and emerging health trends, how is it that this information is going to move from one point to the other? So these structures have to be identified, they have to be effectively communicated, implemented, as well as assessed over time. Then we have the data quality assurance. So over a period of implementation, you want to evaluate the validity and also verify the integrity of the information that you're gathering. Then finally, we have the financial sustainability, which is a major component as well. So it has to be diversified. We have to employ partnerships. We have to explore the option of linking this to the health insurance systems. And we also have to ensure that we secure long-term funding agreements, quality management systems. So we are riding on existing systems, or rather existing programs where we have the ISO 15189 accreditation program. So you will note that all the facilities that are being supported with these platforms are enrolled onto that program. But we have also extended by adding the SLAMTA as well as the certification program, while considering that some of the spoke sites as well as the hub sites will be participating in these programs, just to ensure that even as they feed into this process, they have a certain level of quality that is being observed. Then finally, aspects of monitoring and evaluation. So these are some of the indicators that have been enlisted. So we have input indicators where we'll speak of funding, we'll speak of equipment, we'll speak of human resource, we'll speak of information technology, reagent supply. Then under process indicators, as the implementation is going, we'll look at mentorship engagements, assessments conducted, for example. Then under output indicators, we have the clinicians mentored. We have to verify whether that is being done. What is our turnaround time? How is our diagnostic coverage? Then we have the outcome indicators where we'll also look at the disease detection rate, the reduction in disease burden, as well as patient satisfaction. So just to mention that we are not limited to these indicators, these just form part of the indicators that are to be monitored even as we look at this program as a whole. So what is the expected impact? So this phased approach will ensure a systematic and well-coordinated implementation of the diagnostic capabilities for multi-pathogens. So we want to strengthen microbiology capacity, determine the etiology of specific conditions in the context of people living with HIV in Zambia. And we also want to enhance the accuracy of diagnostics, where we will have to ensure that patients are being managed timely and they are being managed appropriately and not utilizing empirical methods, and just to ensure that we also take care of aspects of antimicrobial resistance, which is a threat that we are facing and even facing as Sub-Saharan as a whole. So with this program, we expect that we'll have equitable access to cost-effective, quality healthcare services as close to the family as possible, as that's what the Ministry of Health speaks to achieve. Thank you very much.
President, very nice presentation, Madam Tairai. Yeah, I'm sure even the network benefited a lot. But just to see the network was with us, we'll run the pause again within a short space so that we get feedback, saying that very nice didactic presentation is done, and I would love to hear from the network. So one of the polls that we did, the first poll, was according to the National Health Strategic Plan, all second-level hospitals are able to do culture and sensitivity of microbiology. So it's a true or false. And in the next 30 seconds, I'll be able to close this poll. glad to see that people are responding, but I'll encourage the network to participate. Remember, this is something that is being rolled out on the national level. And even as you are here participating, you'll be the ambassadors. And you saw the components for this program. It involves a lot of things of which manpower will be needed. And it's the people that are trained that are attending these eco sessions that get to benefit. So please let's participate, even as we are in this eco session. So the next 6 seconds, I'll end the poll. So Madam Taira, you can see that almost 50% people are still split. Others, they are still saying true, according to the National Health Strategic Plan, it's all the second level hospitals that are able to do culture sensitivity. And then 47% are still saying, no, it's not.
Yeah, so for this poll in particular, so the answer here is false. So currently we have 55% of our second level facilities that are able to provide microbiology, culture and sensitivity. And so we are still working to enhance this process and ensure that we can have as much coverage as possible. And this is in accordance with the National Health Strategic Plan 2022-2026.
Yeah, thank you for that feedback. And to move forward, the next poll is the second poll that we did. And even on this one, the network is encouraged to participate. So poll number 2. So the following cadres have a role in this national multi-pathogen diagnostic program. So we have the surveillance officers, the clinicians, laboratory staff, all the above. Following cadres, they have a role in the national multi-pathogen diagnostic program. So let's continue participating. I'll end the poll in the next 5 seconds. Okay, so to end the poll, so we have 97% of the participants saying it's all the above, and we have 1% saying it's laboratory staff and 2% saying the clinicians.
Okay, so for this point in particular, I'm glad to see that 95% are saying all the above, and the answer is actually all the above. So we have the surveillance officers that we see at the highest tier, where we have the genomic sequencing as well as surveillance. Then we have clinicians who are the ones that are feeding into this process by making the requests. Then we have the laboratory staff that are conducting the testing. So all in all, we have all these 3 cadres participating in terms of the National Multi-Pathogen Diagnostic Program.
Okay. Then to run the third poll. So it's the third poll. So this one is talking about the specimens. So specimen types that will be considered for the National Multi-Pathogen Diagnostic Program initially include all the following, except, okay? We have A, which is biopsy, B, which is CSF, C, genital urinary specimen, and D, respiratory. So, except which specimen? Okay, in the next 4 seconds, I'll end the poll. Okay, so this is the feedback. We have 85% saying it's the biopsy, that's the exception. And then now we have 4% saying it's a CSF, 6% saying genitourinary specimens, and then 5% saying it's the respiratory specimen.
All right, so the majority is actually correct. So we did highlight that in the initial phase, we are looking at the respiratory as well as the central nervous system and the sexually transmitted infections. So you will see that CSF, genitourinary, as well as respiratory are covered in the categories that I have mentioned, and biopsies are not covered. So the correct answer is actually A.
Okay, thank you. And then the last poll, which is poll number 4. So this one, it's saying about genomic sequencing under this interesting program, the National Multi-Pathogen Diagnostic Program. The following statement is true or false. All pathogens will be subjected to genomic sequencing. So it's a true or false. And, interesting feedback coming to encourage the network to continue participating. We encourage the network to participate. So in the next 5 seconds, I'll end this poll. So interesting feedback here again. Here we have 44% that are saying true, and we have 56% saying false.
Okay, so the majority in this instance, again, are also correct. So we want to note that selected pathogens are going to be subjected to genomic sequencing. So we'll basically sample certain specimens for genomic sequencing purposes.
Okay, so I'm sure the network has a lot to share with us. And we encourage that those that have questions, you either raise your hand, you indicate by raising your hand, or you use the chat box to give us your question. Yeah, and then now from the panel of experts, if there is any that has anything to add to what we've had, we are discussing today, please feel free to indicate, and we'll be able to give you the platform to share with us. So it's time for questions. So in the chat, okay, I'm trying to see those that dropped their questions. So there is from Damairin Wadia, what is the criteria for referring samples for genomic sequencing? So any of the experts can respond, or even our presenter.
There's a hand from one of the experts.
Okay, go ahead, Tale Mwanga. Dr. Mwanga is one of the panel of experts, and I will be glad to hear from you. Go ahead.
Thanks, Dr. Kawasa, and thanks, Taurai, for that talk. So my name is Tale Mwanga from CIDAS, and I want to just speak to that. So obviously PCR itself and genomic sequencing being quite costly tests, you wouldn't want to send everything to for genomic sequencing. So what you normally prioritize then, if you isolate something that's of epidemic potential, that's one criteria, or pandemic potential. And then with the rise of antimicrobial resistance as well, if we are tracking antimicrobial resistance in a certain pathogen, you want to sequence and see if there's anything of interest. And then vaccine preventable diseases, or if something that hasn't been a common issue, but it's becoming a trend, you want to again look at that. And then the Genomics Consortium also prioritized sequencing pathogens that are of concern with regards to food safety. So those are the 6 categories you could look at it in terms of criteria: epidemic potential, pandemic potential, and microbial resistance. If you are trying to track that, then vaccine preventable diseases rather, and then trend, if it's becoming a trend, and food safety. Thanks.
Thank you so much, Dr. Mwanga, for that feedback. Then we also have another hand from Austin's iPhone. Please go ahead. Austin.
Yes, good afternoon.
Afternoon.
Yeah, I'm calling from, this is the Chipata Central Hospital.
Okay, you're welcome. Please go ahead.
Yeah. So an assessment, this is more health for starters. So an assessment was made as to where a machine will be placed. But at the time, we couldn't visualize the type of machine it is. So having visited Livingstone, I realized our PCR lab is very small. So we have another room that was identified. But my question would be, does the placement of machine also require, say, maybe us getting an extra safety cabinet and things like that? Because our PCR lab is so small, we won't be able to have it placed in our PCR lab, meaning we have to move it to the other room that was identified. So my question is it possible that we can have extra equipment like safety cabinets and things like that? Thank you.
Okay, that's an interesting question from Chipata. Any of the experts can respond to that. Okay, so we have feedback from Patricia.
Yeah, thank you so much, Mr. Hurst, for the question. And it's very good to see that the network has joined this core in numbers. Very good to see representation from the lab and the clinical side as well. So to answer the question from Mr. Hurst, what we need to remember in the presentation that Tarai shared is that the implementation of this program is going to be done in a phased manner. And another key element is that before this program was actually implemented, there were assessments that were done. And these assessments took note of some of the gaps in terms of infrastructure. And there is a plan that will be put in place to see that equipment is placed if you do need supporting equipment, because those assessment reports are available here with the Ministry of Health and the partners that are supporting us. So that is in response to your question. If that was observed in the assessment, it's definitely going to be taken care of. Thanks.
Thank you for that wonderful feedback, Madam Patricia. And then we also have one of the experts as well, Mr. Paul Chogap. You may unmute and go ahead.
Thank you so much, Doc, and thank you so much, colleagues, for the wonderful job that you've delivered this afternoon. Just wanted to firm up on the response that Madam Patricia has rendered. The support is there for Chipata Hospital and all the hospitals that were assessed, all the needs or the gaps that were identified are being addressed in the background. Timelines, I think the MOH will be sharing soon once those become available.
Thank you for that feedback, Mr. Paul. Okay, so we also have another question in the chat box. I'll start with the last one. Okay, this is the feedback that we got. So we have the device techno system. There was a question. I would like to find out how agent results are received by the requesting facility, since only one hospital has been accredited per province. So they would love to know in terms of the turnaround time and also the reporting or the publication of the results once they send the specimens. Any of the experts can respond. Yes, Dr. Mwanga, you may go ahead, and then thereafter, Swelanji will also give us feedback.
Yes, Dr. Kawaso, thank you very much. Again, maybe just a minor correction. I hope it's minor. It's Mr. Mwanga. Yeah, I just came. I was joking with Kunda that you guys have given me a honorary title, which I totally accept. Thank you so much. Yeah, so thanks, Dr. Kawaso. So you might remember from, unfortunately, we don't have the name of the person who has asked the question.
Yeah.
So you may remember from one of the slides that Taurai showed on information management. What we have done so far is trying to create a link between laboratory information and hospital management information systems where possible. But also there are other mechanisms that we are exploring so that the program jumps on already existing frameworks for data and information management. So for example, the laboratory in Zambia has adopted DISA, a software called DISA, which is used in the lab. You can use DISA Web, some kind of extension to show the results to the requesting clinician from wherever they are. But also in some other provinces, we've used mobile phone-based systems like eLab, so that once the result is out, it's sent to the phone of the clinician for quicker action. So we are hoping that as this program develops, those systems will also be utilized and leveraged so that the program does not create a new and parallel system for result management. Thanks.
Okay, thank you. And if Mr. Swelanji also has an addition to that, one of the experts as well, you may go ahead.
Thank you very much, Doc. I think Mr. Mwanga has answered adequately, but just also to mention that not only DISA, but also working with IHM to also integrate the system with Smart Care so that we work on already existing systems. Thank you.
Yeah, it's interesting that we are integrating everything to digital health, which is interesting, and the transitioning is quite smooth. So there is Michael Banda, a very good program and wonderful presentation. Just three things which the presenter may speak to. One of them is reagent security. How can it be assured? The second one is frequent breakdown of machines. How is it going to be addressed? And then the third one, delayed turnaround time. How is the situation? Okay, so those are three questions from Michael Banda.
I can start.
Okay, so Madam Patricia will start with giving us feedback to this one.
Okay, thank you so much, Michael, for that question. It is a very good question, especially with the limited diagnostic capacity that we've had as laboratory services. So it's a very good question to ask. One important element that Taurai mentioned during the presentation is that during the development of this program, there was time that was taken to define how the program is going to be rolled out. And different components of the program was structured in a framework to guide how the program is going to be implemented. So these components speak to how are we going to sustain the program financially. And this is where issues like reagents come in. It's been defined there. And we also want to leverage on stakeholder support and the support that we have at Ministry of Health.
we believe that is going to answer the issue of reagents. When it comes to the frequent breakdown of machines, again, when we go back to the framework, it defines what we're going to do in terms of capacity building. From experience, usually issues of equipment breakdown, sometimes it has a role to play in terms of who is actually running the equipment. Have they been trained effectively? Also, that has a role to play when the equipment is breaking down frequently. And the issue of infrastructure, which is being taken care of, as confirmed even by the support that we are receiving from STIs. Once infrastructure, I mean, the infrastructure that is housed in this equipment is fit for the purpose of that equipment, it also increases the lifespan of the equipment. So I believe the ministry and stakeholders have done their homework in terms of where are they placing this equipment? Is the environment a danger to the equipment, and will it contribute to the frequency of breakdown? That is being addressed. And then the issue of delayed turnaround time, I wanted to speak to the importance of the laboratory network, which was highlighted in the presentation. We have seen that in the presentation, because of the cost of this instrument, it has only been placed in those provincial sites and not at every facility that we have as Ministry of Health. So the laboratory network has a very important role to play there in terms of how are we meeting the turnaround time. The spoke sites do not have the instrument, but they are the ones who will be collecting samples and sending them to the hub sites. So all that implicates on what is the quality of the sample that we are sending to the hub sites and eventually to the PCR lab, and what is the quality of results that we're going to produce and whether we'll produce it on time or not. I'll allow the other experts to also add more to what I've stated. Thanks.
Yeah, thank you so much, Madam Patricia. Mr. Dr. Muvanga, you may go ahead, and I can see your hand there already.
Apologies, it's an odd one, sorry.
Oh, okay, sure. So with this same follow-up question and the same, the transportation, according to the slides, was saying it should be to the lab within the shortest possible time. So how short is this time? Seeing that we only have one facility in each province per se. So if the spoke site is trying to send the specimens, how short and how much time? And are there any measures to overcome the transportation challenges that we experience? It can come from any of the expert panels, from experts or from arrive.
Okay. So if I got your question correctly, Dr. Cavasso, is what is the required time from the time of collection to the sample reaching the facility?
Yes.
Okay. Sui, do you want to take that one?
So maybe I can speak to that if Sue is not going to take it.
Okay, please go ahead, Mother.
Yeah, I think it's a very important question. That's based on two primary considerations. Number one, the science itself in terms of the nucleic acids that you are targeting being stable. And then number two, the balance of the logistical needs and the expenses that can come with these things. So I'll break that down very quickly, and I know that we're about on time. So for the logistical aspects, it's not possible to have these kinds of platforms in each and every hospital. So the modern thinking now in terms of diagnostic strategies is what Taurai talked about, which is optimization. And optimization mainly asks the question, how can we use the least possible resources to achieve the most in terms of diagnostic access? So for example, instead of, and I remember when I was at UTH, we used to have very drawn out conversations around the fact that it's not cost effective to have a hematology instrument at the main lab. You also have a hematology instrument at pediatrics lab. You also have a hematology instrument at the women and newborn, a hematology instrument in the eye hospital, but that was the case. What it does is that you're spending so much first space, personnel who have to manage it, maintenance contracts and all. So what you would want to then do is, if you have as few instruments as possible, then you wrap a specimen referral system around that. So if we have one instrument at the provincial level, for example, then the supporting systems would be, how do we quickly refer samples from wherever these people are, in line with the MOH's mission of reaching everybody and taking these things as close to the family as possible. So instead of patients coming to the provincial level, you get samples to come to the provincial level. So then you build a system, and we've done that for viral load and DID, on which some other samples are piggybacking. So that's the logistical consideration. So few instruments, how can we enhance the specimen referral system? Coming back now to the second one, which is the scientific consideration, you would want to get the samples as immediately as you can to the lab for testing, while your DNA is stable. But because there won't be testing platforms in the peripheral sites, the idea is that you get the samples, when you collect the samples, you separate the plasma and then you freeze. And then when those things are taken to the testing, we would have preserved the DNA. If it's at the facility, maybe within 2 to 3 hours, it should be in the lab. So thankfully, DNA can be stored for a very prolonged time, 6 weeks if it's -20, and even for longer periods if it's -80 degrees. I hope that helped. Yeah, so for peripheral sites that won't have the capability to test, when the sample is collected, you separate the blood from, if it's blood, I'm talking blood. And then the other samples, what we do is we can give you, and I think we did, correct me if I'm wrong, Taurai, so we can give you a full laboratory handbook that has got instructions on the specimen collection, the container that you must store it in, the temperature at which you should store it before and after testing, how it should be transported, and all of that in detail.
Thank you for that feedback. Well explained. Now, Mr. Powell has his hand. May go ahead, sir.
Yeah, sure. Thank you so much. Thank you so much. Thank you. And thank you so much, Muvanga, for speaking to the timelines. Indeed, that's how it is. So as the presenters have indicated, we are starting with the respiratory illnesses, and the sample type is the nasal and oropharyngeal swabs, similar to COVID. But what we'll do as the team or as an action item is we'll share widely the SOP on sample management. But pretty much is the same way we managed COVID in terms of sample collection, in terms of sample movement, it's pretty much the same, especially that now we are starting with the respiratory samples. But the guidelines with specific timelines, if you're storing at room temperature, for how long, if it's at 2 to 8, if it's at -20 or -80 for longer storage, all that detail will be spelled out in an SOP. Thank you so much.
Thank you for that feedback. So let's be on the lookout. The SOPs will be disseminated soon. Thank you so much, Network, for joining. And any last words, Madam Taurai?
Thank you very much, Dr. Kawaso. It's exciting to see the numbers as well as receive the various questions that have been brought forward by the audience. So we have a hand.
Okay, we can get that feedback from
Mr. Nsamba.
Okay, Mr. Nsamba. Please unmute. Your network is so
all right. finish, then I'll put my thank you. I was saying let's tell arguments afterwards.
Okay.
All right, so I was saying it's good to see the numbers as well as receive the feedback that has been provided by the audience. We look forward to as much interactions as possible, and we also look forward to you even communicating this forward to the facilities which you are representing, especially if you are sitting within the different provinces that have already started their implementation. This is in particular Chinsali General Hospital, and that's Muchinga Province. Then we have Lusaka Province at the University Teaching Hospital. Then we have Livingstone UTH in Southern Province. So thank you so much to the audience. This, I believe, is an addition to what we are already doing as laboratorians. So we have to ensure that we, as much as possible, champion this implementation. And let's see where this takes us, even as we speak to support patient care and meet the Ministry of Health mission, which is providing the service that we ought to support, to provide to the community, as well as our patients who are basically our clients. Thank you.
Thank you.
Thank you very much. Am I audible?
Yes, you are now audible. Much better.
Yeah, what actually Taurai has said is what I wanted to say, but now that she has said everything, let me just thank the team for excellent work, like has been mentioned, and excellent presentation. And to the network, like Taurai has mentioned, yes, we are calling it a program, but from our side as laboratory, we are adding a scope what we already do. That's why you saw all the QMSs, the finances, sustainability, internal quality control, EQA is just adding a scope to what we do, and we're also introducing a new machine of test, and that's why you saw you had all the presentation leveraging on what is already existing. The turnaround time at Chipata might not be the same turnaround time at Chinsari. And that's why you saw we are putting these facilities into already existing quality management programs, because if a facility is participating in quality management, they are expecting test could be the same, but the processes of processing the sample could be different. So as this profile is mature, we'll also be communicating the turnaround time at facility level so that clinicians in that province who are accessing this service should know that the turnaround time. So I just wanted to say we are calling it a program, but for us, we are adding a new equipment which we didn't have before. Of course, we had at TDRC, ZNPHI, RL, and UTH, but now we are rolling out countrywide, and this is the scope that we are just adding to the laboratory test profile of the country. Thank you very much, and thank you to the network, and thank you everyone that joined. I'm not concluding because I'm not the chair. I'm just giving comments. Thank you very much, team.
Well, thank you so much. You've actually simplified my work for that wonderful closing remarks. Thank you so much. And just to encourage the network, that there's a link in the chat box in case you didn't register your presence. You may go ahead and just do that registration. Otherwise, thank you so much to the expert panel that was present. Very helpful, and the feedbacks were very encouraging, and we've learned a lot. I'm sure everyone has benefited. Until next time, we'll see you around. Thank you. Thank you so much.